First of all, I would like to thank you and Adam and all the committee for the organization of this workshop and for inviting me. This is my fourth time in Poland, and it's always a great honor to be here with you, to share my experience, to compare my experience with you, and also to be here with John, that is a very expert. So also for me, there is something to learn from this event. So I've tried to make a short summary of what I put in my recorded lectures, and I hope that I have included in this summary all the topics that you are most interested in, but if something is missing, we can also talk about the other part of the recorded lectures and discuss and answer your questions. Here my disclosure, this my participation as has been supported by the International Agency of Atomic Energy. And let's move to the first slide. That means this is an overview of what happens when we are dealing with the PET imaging modality, and we have a starting point that is the choice of a radioisotope that we want to use to label some pharmaceuticals, and then through different steps we can arrive to an imaging of the distribution of these radioisotopes, radio tracers in a patient body or anatomical part of the body. That means that in each of these steps, we have something that is influencing and that has a result in the final outcome of the entire procedures. It's a very complicated process to get the final results, and also the performances, general performances of this kind of modality are influenced by the choices that we do or have been done in the technology that we are going to use. So over the 30 years in which we have used the PET-CT technology, we have seen many advances in technology, but also in the kind of radio tracers that are available nowadays. And we have seen many advancements in reconstruction algorithm that have improved the results, and now we are facing the new instruments of artificial intelligence that are coming into this methodology as well. When we think to improve the performances, the general performances of a PET-CT scanner, we are thinking of two of the most important parameters that characterize a PET scanner, that are sensitivity and spatial resolution. So we are always looking for scanners that have a higher sensitivity and a better spatial resolution. So we decrease, for example, the dimension of crystals, and we make other choice, for example, correction to improve and decrease the spatial resolution of the scanner. And we need also to improve energy and time resolution to be able to be more efficient in the collection of coincidence. As an effect on the images that we will acquire, we want to avoid the movement artifact, but we have also the purpose, if possible, to reduce the dose to the patient. That could be an important issue, in particular when we have patients that are going to be scanned many times during their path to get free from a disease, but also to reduce scan length, to be able to perform the scan in a proper way according to the patient positioning. As an outcome, we will see better the lesions, and we will see better and more the small lesions, and also we can improve the lesion localization, and as well we can improve the quantification of such lesions, in particular for the small one, to be able to identify the different position of the disease in the patient. We can summarize our technology into main parts. We speak of scintillator crystals, and in this case we characterize our system according to the type of scintillator material that is used, on the number of crystals in the scanner, and also on their dimensions that have, as we said, are strongly related and associated to a spatial resolution value, to the performance in terms of spatial resolution. Then we have the detectors. We have moved for most of the scanner available on the market from the PM tubes to the digital detectors, but some scanners are still based on the use of PM tubes, so this could be a choice. And then we have the general architecture of our scanner in terms of number of rings of detectors. That means a different axial field of view or transaxial field of view. For the crystals, we have said that we have many different characteristics and parameters that can be used to evaluate which is the best and which are the performances, the general performances of a scintillator crystal. And for BGO, the most important parameter is its effective number, atomic number. That means that it's very efficient in interacting with in the interaction of the high energy photons, but on the other hand it has a very long decay time that make it unable to be used for correction for the decay time. So we compare, and we can use as an alternative the LSO and the LISO that have a smaller effective atomic number, but on the other hand they have a very good decay time, and those are the crystals that are used in time-of-flight scanner to correct also for the time of flight. According to the detector, the two possibilities are represented here. So we have the PM tubes and the digital detector in general. I'm not going to go in deep in the technology and how they works, but just to have a summary of the advantages of both choices. We know that for the photomultiplier tubes we have a very high gain, so they are very efficient. That means that we have a very low noise in the signal that is collected to be analyzed and to reach the final image, and they have a fast response, and they have a relatively low cost. On the other hand, the digital detector allows the possibility to have a one-on-one coupling with the small crystal, and they have a very reduced volume, so and also they can operate also within magnetic fields. So this is the choice for the scanner PET MRI. According to the general architecture of the scanner, here we have the evolution of the different scanners that have been used since 2000, and according to the length of their axial field of view. And we started with the first one that has had an axial field of view of 16.2 centimeter. And then it was progressively increased to reach some values between 20 and 30 centimeters, but now we have, since 2020, the hybrid total body PET scanner, or large FOV PET scanners that have axial field of view that are almost 2 meters. And the most important parameter that is associated to this increase in axial field of view is the sensitivity. So we are moving from the very first PET CT scanner that had sensitivity below 10, and now we have total body scanner that have sensitivity that are almost 100. And so the big impact on the efficiency in reconstructing and collecting coincidence and reconstructing images. Here we can have one example of the performance of this kind of total body scanners. They are already well described in literature, and so we can find many papers on this kind of equipments, and it has been underlined a huge field of application, a huge possibility of improvement and advantages with this kind of scanners. First of all, ultra-fast imaging. As they have such a big field of view, they have a very high sensitivity. That means that in a very short time we can acquire a number of coincidences that is enough to get a representation, three-dimensional representation of the distribution of radioactivity in the patient. We can have also low-dose imaging or delayed imaging that was not possible for some radioisotopes in the past, and now with this kind of equipments it can be considered. We have the total body dynamic imaging, as we can inject the tracer to the patient in the scanner and follow its distribution time by time. In terms of application, some papers are published that demonstrate the validity of these kind of scanners in oncology, in the field of oncology, but it could be also applied to studies with healthy participants, as they can have image with very, very low dose. We speak of less than 10 megabecquerels to perform a total scan. And with this kind of scanners, we need also to consider the artificial intelligence, the deep learning, as they produce a huge amount of data, and we need some tools to manage all this data. And I think that with this kind of scanners, this is the challenge for the future. To be really efficient in dealing with the total amount of data that are produced by this kind of scanner. At the moment, they can manage only part of the data that are produced in the full field of view. When we want to describe a scanner, we need a system to refer to decide which are the parameters and characteristics that we need to measure and evaluate to have a full view, a complete view of the scanner that we are going to use. And this kind of set of parameters is provided by the NEMA protocol. Here in this table you can see the results of some of the parameters that are included in the NEMA guidelines and that have been measured for different PET CT scanners. And the NEMA is include a group, is an association in which we have all the vendors. This kind of guidelines are produced for different type of equipment, of medical equipments, but in our case we are considering the NEMA guidelines for the PET-CT scanners, and they give a list of parameters and evaluation that have to be done to completely describe one equipment. These kind of guidelines are periodically reviewed to include all the characteristics of new equipment that are put into the market, and so if new instruments or new performances are becoming available on new scanner, the NEMA test will take in consideration also this characteristic to give a full view of the new scanner as well. And at the moment, the list of evaluation and parameters that are included in a NEMA protocol are the sensitivity, the evaluation of the spatial resolution. There's a test, an acquisition to give a general image quality assessment that include also an evaluation of the accuracy of attenuation and scatter correction. We can evaluate through the NEMA procedures the scatter fraction and count losses, as well the random measurements and the accuracy for the correction for count losses and the randoms. And in the NEMA, the general scheme of a NEMA test is to give a general purpose, a general description and general purpose of the test that we are considering. Then we have the method to perform the test. That means that all the phantoms and the tools that are needed to perform in the correct way a test are described, and some option if you have an alternative, all the options are described. And then we have also a precise description of the setting of the phantoms to get the correct acquisition, and also a precise description of the analyzing phase, so how to analyze the results. And for example, here we can see the spatial resolution test, and we have point sources, and the NEMA procedure tell us where to put each sources, and then tell us also how to analyze, and usually we measure the full width half maximum of each source in the different direction, and we repeat according to the NEMA protocol the measure not only in the center of the field of view, of the axial field of view, but also in a displaced position nearer to the edge of the field of view, to take account also to the different sensitivity, as the sensitivity profile quickly decrease as we move towards the edge of the field of view. This is another example for the sensitivity measure. Also in this case, the very particular phantom is well described, and we have some suggestion on how to perform the setting with this kind of phantom, and detailed information are provided for the amount of activity that we need for the sensitivity. For example, it is stressed the fact that we need to measure the activity in a very, very precise way, and as already said by John in the previous talk, we need a calibrated calibrator that is included in the test, periodical test, because it is crucial to be able to measure in an accurate way the activity that we have in the phantom, as well as it's crucial to have the proper length of the line source. But with some of you, I have done this kind of test in one of my previous visits here in Poland, so maybe you now are able to perform this test very well. So when we talk about quality test, we have to underline that they are not a single part, a task of a medical physicist, and that's enough. No, the quality tests the quality controls are a part of a bigger concept, that is the quality assurance program. That means that if we are doing something in our department, nuclear medicine department, for example, we want to perform good examination with the PET or SPECT equipment because a patient is asking for a response, is asking for an evaluation of a clinical request, we have to provide from the first step to the final step, that is the report that the patient brings and take to his referring physician, should be organized in the proper way. So we have to consider all the aspects that can influence the final result. And within a concept of quality assurance, we have the quality system. That means that we have to set some procedures to decide how is the workflow of our patient in the department. We have to establish very well when we provide the radioactivity, we measure the radioactivity, we inject the radioactivity, how we can organize the waiting of the patient for the uptake time, and so on. And within the quality system, that is a very described collection of procedures and documents, we have also the quality controls that can be divided in three main groups. The first one is the acceptance test that we said that usually can be done according to the NEMA reference guidelines, and the acceptance tests are designed usually to establish if our equipment is conform to the manufacturer's specification and also to the request that we have included in our tender that have been described in the offer by the vendor. So we establish if the equipment that we have just installed is okay, we can use because it is performing in the way we expected it to perform. And after the acceptance test, we can make the reference test. That means that we establish a set of quality controls, very short or easier to perform compared to the NEMA test, to be able to perform this test also periodically. So in the reference test, we perform this test for the first time. We get results that will be our reference for the periodical test that could be done in with this different frequency. We have some documents that we can use as a reference for setting our own quality control protocol, and we have a list of tests that should be done, and also a suggested frequency for that could be daily, that could be weekly, monthly, and so on. And according to how we use and what is our experience on the risk of variability of some of the tests, we can also change the frequency with which we perform each test in our center. Moving to the metrics that are used in PET-CT, I have started also in my recorded presentation with the definition and some details on SUV. You have already heard something from John, so I'm not taking too much time to speak of SUV. We have to remember that SUV is a very variable parameter for quantitative evaluation in PET-CT scanners, as it depends on many factors, some of them according to the patient, for example, the patient size, also or also the level of plasma glucose in the patient, but also some characteristics of the scanner can influence the evaluation of SUV, as well as for our ability and accuracy in activity measurements and the measuring time decided and adopted in our center. So it has been described the variation of SUV in clinical application that may range from 5% to 30%. It's a very huge range of variability. It means that we are not so confident on this metric. And for the field of oncology, two different evaluation, two different metrics have been introduced that are the metabolically active volume of a tumor and the total lesion glycolysis of the same lesion. They are related as after we can segment and evaluate the MTV, we can calculate according to the product of the MTV and the SUV value within the volume, the TLG value. The problem with this kind of matrix that can be used in oncological application is the choice of a way for segmenting the tumor, and also for this kind of calculation we can find in literature many papers providing evidence that one method is better than another, or which is that try to establish which is the best, but it depends on the kind of application that we are going to use the MTV for. So maybe we're better to investigate our own situation and to find evidence of what we get with the different situation. In the past, we have used different ways for segmenting the tumors. For example, a fixed value of SUV that could range from 2 to 5, and the 2.5 is a value that has shown good predictive values and prognosis in different applications, but there are also described threshold-based methods that work very well in some specific application. In some particular application, like in brain, other quantification methods have been suggested and described. This method is the centiloid scale that is used for quantitative evaluation of amyloid PET, and it is a normalized evaluation of SUV, normalized to the mean values that come from a group of healthy or pathological patients, and so it is a normalized evaluation that should be free from individual variability, as we can refer to a template. Another technique to bring some quantitative evaluation in the brain field of application is the statistical parametric mapping, the SPM, that is commonly used in different methodology, in PET, in SPECT, in MRI, and it is based in two different part. In the first, we have to align the image, the setting of image, then we have a spatial normalization to be able to refer our study to a template of a different study of pathological or healthy patients, and then we have a smoothing of our images to avoid statistical fluctuation in the data of the image. The purpose is to replace a manual definition and a manual visualization of those areas of the brain that have an abnormal signal with an automatic tool. And so in the statistical analysis of SPM, we compare according to a general model our study with a template of study, and we can identify those voxels or cluster of voxels that have different behavior compared to the rest of the brain and to the template, and so for the clinician is easy or could be easier to identify the origin of the problem and to classify patient according to the outcome. Scanner harmonization is much important in quantitation and also in evaluation of the general performances of our scanner, and I have to hurry up because I'm a little bit late. Yeah, I have a clock and it is too late, but I'll take 5 minutes more, okay? I think. Sorry for that, but I tend to talk too much. When I start, nobody is able to stop me. And so we need a reference to harmonization of our scanner, in particular when we are going to use them in multicentric study, as we want to compare results, and we don't want that a patient scanned in one center get a different result that if it was scanned in another center. So we need a scanner harmonization program that is the EARL harmonization program provided by the group EARL of the Nuclear Medicine European Association, and they provide a way to evaluate the performances of our scanners and to establish which are the parameters and the correct protocols that could be used in clinical applications. So we are talking about clinical protocols to get a result that is comparable to the results of other centers of this reference. Over the year, this program has been updated to include also new tracers, and the instruction for optimizing the protocols are published also for different tracers. Many papers are published with the results, and we can see that the number of scanners PET that have been validated through the EARL program are increasing, are many, and they have increased their number in a relevant way. But what we see is that at the first measure with the EARL accreditation program, we have many scanners that out of the range of tolerance for the coefficient that we are going to calculate with this program, and so they need to adjust the protocol. That means that this is a good way to underline and to check if our clinical protocol is performing in a good way, in a comparable way. Let's move to the second recap. We have discussed in this second presentation all the correction and calibration that we can include in our routine and that are available on the scanners to identify their crucial points and to identify what they do on the data. And starting from the correction for attenuation, in practice we collect with the CT the linear coefficient for the different type of media in the patient, and then we linearly convert these attenuation coefficients into the corresponding attenuation coefficient of the high energy photons of the PET. And so we can have an image quality that is a map with which we correct for attenuation each voxel in our image. It's easy, it's included, no problem with the coefficient, with the correction for attenuation, but we must know that sometimes we can have something that must be put into attention. For example, when we are using contrast medium, we can have a different signal from two lesion, two objects that have the same amount of radioactivity, but we have corrected with the CT in which we have used the contrast medium. So pay attention to the use of the enhanced contrast medium CT in correcting for attenuation. Some papers have demonstrated that according to the clinical results, the impact of using a contrast medium CT is not so big, but and usually expert radiologists are able, and the nuclear medicine physicians are able as well to identify those artifacts that are introduced by the use of the contrast medium, but we must pay attention to that as well. And some other artifacts are coming from the application of CT in correction for attenuation, in particular when they have some metallic implants, or in particular when we have the truncation artifacts due to the fact that the field of view of the CT is, the transaxial field of view is smaller than that of PET, and so some part that are imaged in the PET are not corrected because we don't have information. And for example, in this case, with some artificial tools, artificial intelligent tools, we can simulate the part of the body that is missing in the CT field of view. This is an example of a high frequency artifact from the moving of the liver that makes the map incorrect, and we see the same artifact also in the PET reconstructed images. Another correction that is very important and is available on our scanner is the correction for the point spread function. We know that moving towards the edge of the field of view, the high energy photons may impact on the crystal and go deeper to release energy and produce light in a crystal that is different from the crystal on which they have impacted. And these results in a degradation of the spatial resolution the more we move towards the edge of the field of view. In this case, we can simulate this situation, and usually most of the scanner have the possibility to correct for the point spread function. It's important to check for the performances of this kind of correction, as sometimes they can have can work not always in the proper way. And so we have to check. We have already spoken about the partial volume effect, so I will skip this part, as John has already told you much on it. We have the time of flight correction that is available with some particular crystals. That is a powerful way to have less noisy and more accurate evaluation of the position of the annihilation, and the more the shorter is the difference in coincidence recorded by the two detectors on the two sides of the line of response, the shorter is this time, the shorter is the distance on which we can position the event, and so a more efficiency in the reconstruction. The last correction that could be available on the scanner is the noise regulation correction that is based on the fact that we usually have to select in the iterative reconstruction algorithm the number of iteration and the number of subset that we perform to reach an acceptable value, and we are not able to reach the convergency of data as the iterative reconstruction isn't able to put some limit to the difference between two voxels, two adjacent voxels. And so if we increase too much the number of iterations, we will get very noisy images. And so to control the noise in the image, many systems are provided to, and they include in the calculation of the function a term that have the purpose to is a sort of penalty term that have the purpose to keep low the difference between two adjacent voxels, and so to avoid the statistical fluctuation that are typical of the iterative reconstruction with a large number of iteration. So with this kind of correction, we can increase the number of iteration and reach the convergency of the image. Motion is another important issue, because it has effect on the lesion detectability, on the quantification of SUV and volumes, and also introduce some artifact due to the misalignment of PET and CT. And so many different ways to correct for movement have been described, introduced, and can be used. And the last one is a tool of artificial intelligence. They have been described in the recorded presentation. I think that if you have any question, we can talk later of it. In particular, motion management is important when lesions are very small in particular organ that are lungs and liver, when we have equivocal report, so SUV values that are in a range of equivocal report, and it could be useful also for contouring volumes if we are going to use our PET CT acquisition for RT application. Last part, artificial intelligence, many terms. We have many different words that we can use in artificial intelligence. This is a general scheme. So artificial intelligence is a part, all the technology that enables a computer or a machine to simulate a human learning process. Within the artificial intelligence, we are particularly interested in machine learning, that is the development of a computer that is able to learn and adapt without following explicit instruction. And within the machine learning, we have the deep learning, that is a subset of machine learning that uses multi-layered neural networks called deep neural networks to simulate the complex decision-making power of the human brain. When we see something and we ask to our brain, what am I looking at? Our brain records shape, colors, dimension, background, all the features of what we are looking, and gives us the answer. That's the way that the deep learning works. So we have many data, we establish and we identify our model, then we train the model, so we check if the model is working properly, so we compare the model prediction with the ground truth, and then we improve according to the loss function, that is the difference between what the model says and what we know that is real. And the first part, the training part, is much important. There are some differences between machine learning and deep learning. As in machine learning, we need the intervention of the user, so we are going to define all the features that will be included in the process, while in deep learning this kind of selection is done by the system and it is updated as far as new evidence of failure of the model are available. And many different purposes of artificial intelligence are been identified, so for image quality, for noise reduction, correction, dose reduction and time reduction for acquisition. We can use the artificial intelligence to optimize protocols automatically for positioning the patients, as we have seen in the recorded lectures, for artifacts, for diagnosis, as said by Darius previously, in reporting and image segmentation. And at least almost all the anatomical regions of the human body are included in the list of the types of study that can benefit from the artificial intelligence. So lung and all the chest pathology, the breast cancer, the heart and cardiovascular disease, abdominal disease, brain and neurological disease, and whole body imaging. And what can we do? We can buy some tools of artificial intelligence or collaborate to create some a new tool or develop some in-house tools. But we have to remember that artificial intelligence is a medical device, so it needs a pre-market approval, a post-market surveillance, and a post-market significant changes, as some evidence are available that he needs updates. And according to the role of the medical physicist, as they can replace, this kind of tools can replace the role of the physicist in some steps of our tasks. We have to remember that we must guarantee the consistency of quality also using this kind of tools. So our role in the use of artificial intelligence is crucial and important as well. So I think I can stop here as I've talked much.